Howdy. Howdy at home. I'm Tim Garson, since I forgot to introduce everybody last time I was up here. What I thought I would do is let each of us introduce ourselves. The boss for tonight is Osama Mikhail. I can never introduce him without thanking him. He's not happy he did this, but he dragged me through the Masters of Public Health when I was paralyzed, and sort of changed my whole life. And so any chance I get to say thank you, I get to say thank you publicly. So why don't the rest of us introduce ourselves, and you're in charge.
So I'm going to introduce you.
Oh, me?
Yeah, you're the poster child for healthcare.
Oh, yeah, it goes this way and this way, right?
No, I'm on the faculty of the School of Public Health, and I've been there for almost 30 years. 30 years, and I just retired in August. But I managed to talk Julie and John into participating in this thing. And the first person that I thought of was Tim Garson, who stayed on the panel. And I think you substituted for someone, I substituted for somebody, and you substituted for somebody. So we're all substitutes except for Tim. So I don't know, ladies first, you introduce yourself.
Nickell. I'm happy to be here tonight. I am the Chief Financial Officer for Baylor College of Medicine.
I'm John Adams. I began my career in the Texas Medical Center a long time ago with Methodist Hospital. Spent 11 years there, then moved next door to Texas Children's, and for the last 25 years I've been working with a cardiovascular network that Denton Cooley started, the Texas Heart Institute, and expanded out to Methodist Hospital, and running a technology company that we recently sold. So right now I'm semi-retired, so I haven't had to think about healthcare in about 4 months, Osama.
I know, and you said this is the most you've had to think, period.
That's right.
No, you don't have to.
Oh, you don't have to think. Yeah, it's Tim. No, but no. So we're very fortunate to have John and Julie here, and Tim, of course. I had organized this around 6 key questions that were pressing, and maybe the first one, and Dr. Garson is going to take the first question. We can still do this. And Adele, because I don't know how to use a computer.
Are we going to do that?
I'm going to start with a poll.
Well,
Really?
so the common view of healthcare. Let me back up a little bit and say there are 2 parts to healthcare finance. There's the financing system, which is where the money comes from and what it gets distributed to, what it gets paid for. There's the management, the financial management of institutions, whether it's physician institutions as Baylor, and you said you were primarily on the physician side too, but it could be hospitals as well. How do they manage their sources of revenue to be efficient contributors to the society? So the common view is that healthcare in the U.S. costs too much. Do you all agree? Yes. All right. So one of the questions, and we're going to ask Dr. Garson this, is what contributes to the fact that healthcare costs too much? Is it the physicians? Is it the hospitals? Is it the pharmaceutical companies? Is it the insurance companies? Or is it something else that we don't know anything about? What is it that really makes healthcare so expensive in the U.S.?
Now, are we really going to do this thingy? Or
well, we're going to, yeah, I think.
So,
I think we're going to.
So we're going to let them pick first.
Yeah, they're
Well, let's see what their opinion is, and then you can answer it.
Completely upside down, and then.
Any way you want to do it.
Yeah, let's do it.
Yeah, let's just see what they think. The pharmaceuticals.
You guys all know how to do this with the sign up for? Wow, I'm glad we're doing this. This is fun. Other. Yeah.
It's something
Ice
else.
cream. Doctors, hospitals. Huh. Okay. What? Getting there. Other. Hey, we got to find out who.
Well, the
others.
doctors they're not at all responsible for anything?
Just you wait. Hey, can we ask?
Oh, 8%.
Oh, there we go. That's just because I answered twice.
Are you rigging?
No. Could we ask people what other, would they be willing to say what other is? Huh?
Yeah.
Well,
Yeah.
it's
Other is
something else?
because it's more than one. It's everything from utilization to the physician's pen,
okay.
to hospital costs, which are the majority of the healthcare costs. I mean, you can go on down the line, so it's a multiple.
Okay, got it, all right. So, how many of you were here for the first one of these? Okay. How many of you have Alzheimer's? Okay. So the good news is, if I say the same thing, you're going to just say, heck, you just said the same thing. So that's no fun. But I think an approach, and it's not the only approach, but an approach to thinking about this is waste. And it's Don Berwick's 6 ways of categorizing waste. Now, I think it does lead to some discussion about what did Don mean, and that might be sort of a neat discussion about what everybody else thinks. But Don's 6 areas: overtreatment, price, administrative waste, fraud, readmissions, transitions, and safety. Those are the 6. Now, I would love to hear, and oh, by the way, some of that has something to do with physicians, right, ladies and gentlemen? Like all of them. Interestingly to me, when I was, the book's about to get published, and I was looking up fraud and abuse, and I figured, damn, that's a lot of money for doctors to be wasting. It ain't the docs, it's the durable medical equipment people. That's the highest when you look at how much money gets spent on fraud and abuse, darned if it isn't the durable medical equipment people. So if it's okay with the boss, what do you think about those, and what do you think are the relative, what's the biggest, what's the littlest? Just
Yeah, let me ask one question. When, that other, which is the biggest, is that because it's a combination of everything? That's what the other means? Let me take it out. Which is the most important? Which is the most important in contributing to costs? So you have to.
But can they change it, Adele, or one is it? How about wipe it clean and do it over? Can we do that? Hey, listen, huh?
Just do it again.
Hear your response to your phone and take it from other to something else.
Or you could steal somebody else's phone.
I reset it now.
Here we said, okay, so other would be something other than doctors, hospitals, pharmaceuticals, insurance companies. But which is the most important contributor to the cost of health care in the U.S.?
And it's A, B, C, or D. You ain't allowed to do other.
Unless it's ice cream.
Yeah, ice cream, but then that's doctors prescribing ice cream stuff. So. Or hospital cafeterias.
Golly, nobody thinks the drugs cost too much.
That's sort of interesting. Huh. You want to? I've got a few, but
Yeah, go ahead.
I mean, would anybody that said insurance companies, all 400 of you, want to speak to, if that's okay with you, what does that mean? How is an insurance company the most responsible for the price of healthcare? Would somebody who answered it like to sort of speak to that?
No.
Just kidding?
I'm surprised that pharmaceuticals was not
Me
listed.
too. Drugs.
So just
But-
like in my
opinion, of these four, I believe that insurance companies have the most control to fix costs in this healthcare system as a whole.
And how would they do that? Hold on to the mic.
Just in terms of reimbursement for procedures, reimbursement for medication, kind of having all of these specific costs associated to procedures.
Well, related to that, and this was something John told me, because I started in this business a long time ago, and I thought everybody had gotten more sophisticated since then. But what were you telling me, that the way in which those contracts that the payers offer out, how they're negotiated?
I don't remember.
You're not old enough to say that.
I'll answer that, but before I do, I want to go back to my pharmaceutical. It links back to your insurance company question because I think they're related. I read recently where, most insurance companies outsource their pharmaceutical management to PBM companies. And rebates, huge rebates are given by the manufacturers, but they're given to the PBM companies, to the insurers. They keep them and split them, and that's not passed on to the consumer. So when people complain about pharmaceutical companies, they really should be complaining about the system and the way the process gets carried out, and the savings doesn't get passed from the manufacturer to the consumer, the patient. It's kept by the insurance companies and PBM companies. There are all kind of examples of compound pharmacies or direct pharmacies that you can get your own rebates as long as you don't go through the insurance companies. And I think that's proving that out.
Okay, John, teach us, or at least teach me, everybody else. Of course, everybody else is smarter than I am. Everybody else may know the answer to this. That rebate, that gets really opaque to me when one is trying to get out there and say, how are we ever supposed to reduce the price of prescription drugs? And all of a sudden, I get really opaque with rebates. Is there a common fourth grade level that you could explain to us sort of how they're set, how they work, how they're negotiated? You got a manufacturer, you got a PBM, you got an insurance company, you got a pharmacy, you got a retail pharmacy. How does that work? Because I sure can't figure it out.
Yeah, well, I can't either. But I do know that you can get online to GoodRx, which is one example of a website. You can put your prescription in there. It will tell you where you can get it cheapest, or you can go through directly to some of the websites, to the manufacturer, get it, and get a rebate yourself, as long as you don't report it and pay a co-insurance through your insurance company. A lot of times, it's cheaper to do that, especially with large co-insurance, to do that rather than even report it to your insurance company. So the rebates are there.
I've got another couple of thoughts on the insurance companies. And I'm actually hoping, because this will come across as jaded, but that you guys shine a more positive outlook on the payer side of the industry through today's session. But I could make an argument that you look at A, B, and C, and that there is a altruistic benefiting society piece or drive to those organizations, be it doctors, hospitals, or pharmaceutical companies. Insurance companies, I could make an argument, have not innovated ever. They're for-profit companies who are trying to make the most money on their patient population that they can. There's also, you can go to any doctor, you can go to any hospital, you can't really go to any pharmaceutical company, but there are 4 or 5 major payers.
Yeah, I think you're right. I think you're right, because I do remember a few years ago, saying to the president of Blue Cross Blue Shield for Texas and three other states, what is the impact of the ACA on you? He says, I don't know and I don't care, because all we'll do is, if the costs of those 3, doctors, hospitals, and pharmaceuticals, go up, we'll just increase our premiums. So, but I said that's good for the short run. In the long run, we expect you pharmaceutical companies, you insurance companies, to negotiate better rates for us, but they don't.
One thing, I am not here to praise Cedar, but figure into the equation that 75% of what Blue Cross does is third-party administration for self-funded employers. That's 75% of all of what Blue Cross does. Now, I would, lay a fair amount of blame for this craziness at the feet of the employers, me. And I would, if you think about, they're paying it. And what obviously the insurance company gets a cut. And of course, the insurance company, gets the cut. The higher the charges, the more money the insurance company gets. So the insurance company has zero incentive to cut cost. But 75% of that is the employer saying, I gotta have this for my employee, or I don't care. I'll give you one horrendous anecdote, and then John wants to talk. John's got the thing. I was and telling you I was in Hartford is meaningless because every insurance company is in Hartford, so that doesn't tell you anything. I was in Hartford about a year ago, talking to the CMO of one of the large insurance companies who was a dean. He went to dean's camp when I was a dean, and so we sort of became friends, and he did the smart thing and went and made a bunch of money. And I was talking to him about system change without mentioning what I was actually doing there, but I was talking to him about possible ways where they could improve quality and reduce cost. And I did my dog and pony show, and I got to the end of the hour, and there were 15 people at the beginning of the hour and 2 at the end of the hour. He figured he had to sit there for the whole thing. And I said, okay, what's going on? He said, we don't need to save money. We make all the money we need to make. We don't need to change our systems because they work, and they work for us. So we don't need to change our systems either. Now, this is one of the 5 immense insurance companies in the country. My guess is that's not a dissimilar thing at, no offense, Hospital X, Health System Y, Insurance Company Z. They're okay the way they are. Fascinating, and then I'll shut up, and I know John wants to talk. We all knew this. We all knew it. Some moron finally wrote it up in JAMA about a month ago. Why did the CMS hospital readmission penalty fail? Why did it fail? Because it failed, right? The hospital readmissions went down about 2% nationally for the first 2 years. Boom, absolutely flat for the last 5 years. Why? Because the readmissions weren't high enough. And so the hospitals, and I mean, lots and lots of personal people have said this to me. Oh my God, are you crazy? We love readmissions. Keeps our beds filled. And we get, and yeah, we were worried about 3% of Medicare expenses going as a penalty, but it's 0.4%. Who cares? So they would much rather have the readmissions and get the money. So those of you that are, so I guess what I'm saying is, okay, let's blame the insurance companies. I'm sorry, I want to blame everybody because it isn't just the insurance companies. It's all of us. John.
Yeah, I sat on the other side of the fence for over 20 years representing employers and working on the healthcare economics. And I saw the evolution of how insurance companies attempted to manage costs. Not manage care, but to manage costs. And it started with traditionally what they did is they had the usual and prevailing rates. And that was something that was for years. Well, hospitals and physicians realized what they would do is they would go into a community, they would array the costs for a procedure from high to low, and they would take the 90th or the 80th percentile, and they would pay from here on down, and anything in excess of that would be of usual and customary. So in order to look at that, the consultants came and went to the hospitals and went to the docs and said, okay, what you need to do is raise your rates 10% each year, because they're going to come back and they're going to survey you, because they survey you every 6 months. And if your new rates are moved up, well, your actual reimbursements are going to move up an average of 10% or whatever the amount was. So then the DRGs came in and they began to look at using DRGs, and then they said, well, we're going to start pushing for volume discounts. And so they said, we're going to take your billed charges and we're going to force you to look at 20, 30, 40% off that number. And you saw a slight bend in the curve in the 1980s or so for a period of time, until the hospitals and the consultants came back and said, just keep pushing this up, because it'll be 30, 40% of a larger and larger number. And one of the unintended consequences of that was a Medicare rule that said you couldn't charge Medicare below what you did anything else. So they had to put that charge up, and the difference between this and that billed charge then became the amount that the uninsured had to pay, which is why we have this incredibly crazy, if you go to a hospital and you get a bill and you don't have insurance, your charge is up here while managed care companies pay here. So it's been, and then we've looked at the bundled and the unbundling thing, where the consultants went out and they taught hospitals how to unbundle the charges to get more. So you could charge for every time they cut on certain fingers, and then they'd go to the managed care companies to say, these people are unbundling, you need to rebundle these things. And so we've seen the cat and mouse game for 20 years now, in terms of how people are trying to increase revenue with how they're trying to cut. So it's not, to me, it's not that the insurance companies don't care, because they've tried. It's just that we've got such a convoluted financing system. Healthcare money's coming in from research grants, coming in from philanthropy, coming in from in-kind services, coming in from revenues from employers, coming in from government contracts. You don't have a rational economic system. And because of that, we've seen prices go all over the place. And so, to me, it's the entire financing system. No matter what you do, and we've seen the literature that says doctors control 85% of all healthcare costs with their pen. When you prescribe pharmaceuticals, when they're going to go in, and then pushing them out of the hospital, all of those things, the physician's pen controls utilization.
Well,
And
the one that I want to, and then we've got 5 others, I guess, and I'm going to shut up. The one I only because it's a bugaboo to me, it may not be to the rest of you. It's about $182 billion a year in overtreatment, according to Don Berwick. Now, one more time, $182 billion a year. That's about what paying for the uninsured would be, right about there. So if docs quit overdoing stuff, we could pay for the uninsured. Now, do they really? And one, I think, an unsung hero of this discussion sits to my right, as follows, and then we can go on and I'll shut up until I don't. Atul Gawande. We know who he is? Anybody know who he is? Anybody not? Anybody so asleep they couldn't care less? Atul Gawande, neurosurgeon, Harvard, writes in the New Yorker, hadn't written in the New Yorker for a while, writes articles that should be about 2 pages, and they take 32 pages. Other than that, okay, he went and do you know, I'm sure you do. What was, because McAllen, Texas was the second most expensive. What was the most expensive?
I thought it was McAllen.
No, I think it was the second most expensive. Anyway,
That he compared it to El Paso.
He goes down and finds out that McAllen, Texas, Medicare cost per person highest, second highest in the country. What? Well, you'd say, well, okay, how can that be? Well, I would think a gentle way of saying it is that that's just the way it's done in McAllen. They don't wake up in the morning and saying, hey, I think I'm going to charge Bertha, 15 for 15 angios. And I think I'm going to refer Charlie to, the ophthalmologist. It's just the way it's done, I believe. So I thought. So I figured, okay, relatively small place. They all know each other. They all charge a pant load. And they make a lot of money. Along comes the article by Mikhail and Company in Health Affairs that compares Medicare expense to Blue Cross expense. And damned if the Blue Cross expense isn't right on the national median. What? Yep. They are bilking Medicare purposefully. They know exactly what they're doing. They know exactly who they're billing. And they know that Medicare has no oversight on what is ordered or paid for, whereas Blue Cross has plenty. So that, to me, is one of the most damning articles on record that doctors do this stuff on purpose. It ain't, oh, by the way, it's real. The one that I'm trying, if I could find it, there's an article, because when you go and ask a bunch of docs, why is medicine so expensive? The word out of everybody's mouth is malpractice. If I wasn't going to get sued, I wouldn't do this stuff. Well, we're going to try and redo this. There was an article that I just can't find, and I may be remembering it wrong, but basically they asked the docs two different ways. One was blinded and one wasn't. And the one that wasn't blinded, where they had to vote and da-da-da-da, it was malpractice. And when they could keep their, and it was money. 71% in JAMA. Last year, 71% of physicians said, those other docs order stuff to make money. Not me, but those other docs, 71%. So there is some of this, therefore I believe that we can attack. My personal attack is on trying to salary all physicians. That's what I'd like to do. 68% of physicians nationally 2 years ago in our survey said they want to be salaried. Mayo Clinic, Cleveland Clinic, Kaiser Permanente, Baylor College of Medicine, da-da-da-da. So it's not a stupid idea, but the data that says if you do that, you will save a bunch of money are lacking. The best articles I can find are from South Africa 30 years ago. So I cannot prove that that will actually make a difference. Yes?
So you use the term doctors, but my wonderment is these doctors are with potentially an ACO, that ACO may have certain requirements of their doctors to do certain things a certain way. Not the doctor itself, but the organization that may have facilities, resources, clinics that need to be supported. So are you dissecting out the doctor individually or the organization that they're with that may have certain requirements of care?
Let me tell you what I think, and then I really am going to shut up. I think it's exactly the opposite of the ACO. The ACO wants to save money. The ACO doesn't want doctors to do anything. The hospitals that own the doctors want them to do plenty. But the ACOs don't want them to do anything. That's the whole deal with the ACO, is that any less service in an ACO drops to the bottom line. So it ain't the ACO.
Even though that ACO may have infrastructure that then serves rather than send them out outsourced, but they have, you get your labs there, you get your MRI there, you get your.
The ACO wants no tests. The ACO wants no hospitalizations. That's what the ACO wants. And obviously they want good care and they got all that stuff. But the stimulus in the insurance company is to do less, the ACO is to do less, others is to do more. Yes, sir.
Yeah, one comment. I'm originally from Finland, and we have a very different healthcare system in Finland than in the U.S., and I've lived here for a
Thank
couple
God.
of years. And but a couple of things, like I think that if doctors are incentivized for seeing patients more and more, and
Here
if
or
they're-
there?
and if they're incentivized in prescribing, then that's what they will do. And that's the difference in the Nordic model, that they are not incentivized to do that. They're incentivized actually to try to get people out of the hospitals. In the governmental system, we also have a private
How are
system.
they incentivized? Teach us. How are they incentivized to keep people out of the hospital?
Well, like in the public healthcare system, the docs make a fixed fee. You know, they make a fixed salary a month. They cannot earn any more than that. And that's their contract is a fixed contract, and then they either take it or not, or they go to the private side or the public side. But that's kind of like, the system is very different in that sense. And definitely there are pockets of private, providers as well, and occupational healthcare is largely private in Finland, but most of the basic healthcare is kind of government run, and it's like fixed salaries, and there's no incentives for any of the doctors to see more patients to make more money.
Related, John, to your point about the most expensive the cost of technology, the pen. So I attended a conference where they said this is the most expensive piece of technology because the doctors write the orders. So this is the most expensive piece of the technology, which is kind of what Tim, you're saying. But listen, let me go back to something that I think that affects Julie and John just a little bit, and I do remember what you said to me.
Well, yeah, and I was going to come back and answer that.
You're going to answer it. Go ahead.
John actually came close to answering it based upon how insurance companies address what they pay in the market and how they negotiate. But basically what I see today is they negotiate with providers based upon percent of RVRVS, percent of Medicare, as low as they can get it. They can get 105% of Medicare, 110, 95%. That's how they negotiate to keep the cost down on what they pay out. But then how they sell against other insurance companies to the employers to get their business, their book of business, is based upon a percent off of gross charges. So they look at the provider gross charge, and if they can negotiate this, is that a 40% spread versus a 35%? Has nothing to do with utilization, has nothing to do with anything controlling the cost of care, but the employer, through their consultant, Mercer, whoever it may be, they go for it.
Right. And many times what they do is they say, here's what they're charging you, here's what we'll negotiate,
Right.
give us 10%.
That's right.
Right, which is the way it was 30 years ago. I'm just surprised that it hasn't evolved. And I asked Julie the same question.
What is
Julie
your
and
name?
John.
I'm sorry. Michael, you made a very good point. The insurance companies are not creating value for the employers. They are not being innovative. They have billions invested in their fee-for-service systems on how they approach the market. There really hasn't been any incentive, and they're being led by CMS on their value-based programs, and they're being led by employers who are pulling out of the ASO arrangement certain segments and going direct to providers on Center of Excellence programs, which is working very well. And that's why commercial insurance companies are now developing programs.
Right, so I'm making a bit of a leap of faith here, but I believe that these were, between John and I and this discussion, were the reasons why the Cadillac tax was brought about to disincentivize employers who cover the vast majority of Americans who are asking for these robust, over-the-top plans, right? So maybe you explain why the Cadillac tax was such a failure, and how can we present it or put an incentive or something in place moving forward to stop this if we think that's
We'll let
Sort of
Julie
the
answer
cause.
that.
Well, so I work for an institution that employs all the evil doctors.
No,
And
you employ the good doctor.
the good doctors, no, that's true. It's being recorded, they're all great doctors. And we have an employment model, obviously, it's an academic center. But the Cadillac tax is not dead, maybe that's not what you're suggesting. It's still very much part of the ACA, it's just been deferred.
Yeah, I mean,
Right, it's been deferred
supposed to be implemented
2022.
2 years ago.
Right, and I will say that the way that, first of all, I think healthcare is a complicated system, and like any complicated system, market-driven system, every actor in that system wants a piece of the margin. So what you all have been describing is every individual actor in that complicated system trying to carve out their piece. That's sort of normal free enterprise, okay? It's the way we sort of operate in a free market society. And this market is characterized by a high level of information asymmetry. So you know when you go and purchase something typically that you need to buy it, you have enough information to choose between A and B. But if you're a patient and you're ill, most patients don't have any medical training. They trust what they're told. They, are not going to necessarily go shop around and ask for a second or a third opinion. That's very culturally, at least, maybe that's changing now, but certainly culturally that has been, and something that people would not normally do. And so I think that makes it more complicated in this market because of just a lack of knowledge and information on the part of the consumer. So the consumer is sort of sitting here, but not really affecting the decisions that are being made that drive cost. Going back to the Cadillac tax, employer insurance is sort of an accident of history in this country because of the freeze on labor back in World War II era, and so it was a way to attract labor to allow people to have, tax-free sort of benefits. And it's sort of, obviously it's now very firmly part of the way healthcare in the United States is financed and probably would be very difficult if ever overturned. But when I look at the benefits, for example, that Baylor College of Medicine offers its employees, they are not exorbitant healthcare benefits. They're what we're all sort of accustomed to. I'm assuming we're all sort of insured by an employer-based plan. So the ACA also built in preventative care. So there's certain things now that, screenings and things, which are all great, that are now you have to offer your employees. So that raises those premiums that you're paying or the costs that are, attributed to an individual. The threshold's pretty low on an individual basis, above which there's a 40% excise tax. So it's a pretty significant tax. And, when I look at our employee data and look at the potential impact of that Cadillac tax, it's pretty significant, and it has an escalator in it. So over a period of, 10 years, it grows by like 200%. So when I look at Baylor College of Medicine, I'm like, okay, how are we going to avoid this tax if it eventually is something that doesn't get overturned, and it's a big part of the financing of the ACA. So Donald Trump and the current administration had an opportunity in the Tax Reform Act from a year ago to overturn that. They didn't. They've taken out a lot of the other pillars of the ACA from a financing perspective that were embedded in the tax code. They did not do anything with this one. That's puzzling to me. So I think it's there and it's been deferred. But on our employee base, I would say that the tax starts out at like $2.5 million and it escalates to 30. I mean, that's a significant excise tax for benefit plans that, if you look at the way the tax is calculated, if you have a lot of women who are going to have children, okay, or if you have a lot of older people who are going to, just because of their age, are going to use more health care, that tax hits you square in the middle. You can't plan design. You can't change your plan enough to avoid it, right? You can't shift enough of the cost to your employee base to avoid it. You can't not offer services that you're required to offer. So it's a difficult it's a difficult nut to crack. And I think in the marketplace, certainly, I think, and it's really puzzling to me that academic institutions have not jumped on sort of a lobbying around this. A lot of for-profit companies obviously have jumped on sort of advocacy in Washington, D.C. about overturning this, but academic institutions really haven't. And I think it is because there's sort of this, and I'm rambling, I'm sorry, but sort of,
You're really good.
sort of this, I'm worried
I
about
haven't
this tax.
shut up this long in a long time.
This, that are worried about the persona that, your question sort of insinuated. It's a Cadillac tax, really rich plan, evil employers need to change. But I'm telling you, the way the tax is calculated, you really can't structure your insurance programs in a way where you can avoid it. And they're kind of normal benefits that people are accustomed to receiving. So it is a difficult situation. And it is a core financing mechanism for the ACA. So, and I'm not sure that it's going to go away. So when I look at with Mercer, who's our actuary at Baylor, and we look at our plan design, we are making changes, whatever changes we can make to try to reduce that, including shifting, costs back to our employee base. But the only way to avoid it totally is just not to offer insurance. And that really wouldn't look very good for an academic medical center not to offer its employee base
Or
insurance.
reduce the cost of healthcare.
Or
by the
overall
way,
reduce the cost of
right?
healthcare.
Or reduce the cost of healthcare.
Yeah.
A question, and there are 100 people. A statement and then a question, because I'm interested in this notion of salary.
Yeah.
And you would likely, I remember I made a salary when I was the dean at Virginia, a higher up surgeon was salaried. Made $100,000 a year in salary. And he was salaried. And he made $1.1 million in a bonus that was entirely related to volume. And so that would be known as BS salary. Do you have that kind of bonus system, and not being, I'm not talking certain, but a very good, one of the very top medical schools in the country, have you got that same sort of deal? You call it salary, but
No. No, we benchmark our provider compensation to AAMC, typically AAMC benchmark salaries for this region by specialty.
But no bonus?
There's different departments will offer different small bonuses for different, it's not that sort of ratio as you described. I mean, most of the compensation is fixed and pegged to a benchmark. And then there are bonuses, either, sometimes they're research-based bonuses, education-based bonuses, because we have 3 missions, education, research, and clinical, and sometimes they're quality-based bonuses. And in certain, we have providers in most of the hospitals in the medical center, in some of those in some of those provider contracts or affiliate contracts, there's also a small productivity bonus, which misaligns the incentives. People have picked up on that. But it's not a significant part of the comp.
It's a catch-22, and then I'm going to shut up again. What everybody is not a terribly specific word. What one hears when you take docs from fee-for-service to salary is they put their feet up on the desk and they don't do anything. And you hear this over and over again. So you sort of have to do something that says you can't do that. You have to do something that says, no, you actually have to see patients. And unfortunately, that starts to look like a bonus for RVUs all over again. So it's a sort of a catch-22. But anyway, I'm going to shut up. You got all kinds of people want to talk.
Tim, I'd like to respond to that. I've never really been an advocate for salaried physicians, but you make a very good point. I think there are ways to achieve the objectives with salaried physicians, private practitioners, academics, through networks, sharing information, agreed upon protocols, and through bundle pricing or variable-based programs, however you set it up. But you don't have to be salaried necessarily. I think there have been some articles.
How would you do it not salaried?
Okay, there have been some articles over the last couple of years that salaried physicians by hospitals don't necessarily reduce cost. I have personally seen over the last 3 years, though, physicians who have gone from private practice to being salaried, their productivity, and productivity is defined by billings, goes down over 10%.
Well, that's what I just said. That's
Yeah.
the problem. And I don't know how to fix
And I don't
that
know
one.
why.
That's a
Well,
problem.
so Tim, I think part of it is to give the same incentive to the hospital as the physician, because what the hospital won't do is renew the physician contract if they're not productive.
Exactly.
Which means they have to see
They bought it for a
physicians.
reason. They're losing money on their salary. They need them to provide
Right.
tests.
That's the Cleveland Clinic model is you get 1-year contracts.
So I
That's
think
the Cleveland Clinic model.
bundling is
Well,
not
here's the,
bad.
so bundling, the article came out in the New England Journal 2 weeks ago about they mandatory did bundling for hips and knees, mandatory. There's a 5% reduction in the bundled payments. Where did that come from? Not one bit from any behavior other than not sending people to rehab. It's the only change that bundling made.
On
So
joints.
unfortunately, we ain't there yet. The docs are still figuring out how to get around it.
Well, I
It's the
think
only
one of,
change.
I mean, we are, and both you guys, but we are going to answer some of the questions. I hope we get to there are 6 questions. So there was a question on access and coverage. Are they the same? And I think Tim's going to take
Well,
that
but
one.
I think Julie, I think there are a bunch of questions for
Yeah.
Julie.
Go ahead.
Well, yeah, maybe like a comment, like the cool thing I think here in the US system is that the employers have such a big buying power. So like that's kind of a unique thing. Like the employers can actually, when they're buying a lot of healthcare services, I think it's like tens of billions of annual in the US or something like that, you can actually like influence the market a lot. Like, you know, we're a small provider for a specialty network for mental health care, behavioral health, and you know, we've kind of developed a model for an outcomes-based model where we only charge for outcomes. And I believe that that's what I'm seeing actually now happening, you know, with also other like disease areas like diabetes prevention and diabetes treatment and so on, where actually small providers are starting to like put their fees at risk and making contracts, like value-based contracts with, you know, employers who are usually like the ones that are, you know, can move quicker, let's say, than like the traditional insurance companies. And I think that that's at least something where there's a great kind of like place for change and good influence from the employer. So have you been thinking about something like that, like kind of like, you know, you have an immense power to purchase these services from different vendors and different benefits. So what kind of, would just love to hear your thoughts on that.
I agree with you. I think you might have mentioned, somebody mentioned the earlier about employers going directly to centers of excellence. I mean, I think you're starting to see that. And each individual employer is a separate entity. So your biggest, you know, payer is still the government through Medicare. So every individual employer is, you know, only going to be as good as their individual negotiations. You see, at least with us, we've tried to pull together, you know, clinically integrated networks to provide access, because you have to think about, you know, where your people live and where they're going to try to access care. And every market is different and has to be, I think, looked at differently. And that's where we have probably tried to look at access and cost for our employer base. But we're also looking at the drugs that we cover and the therapies that, you know, we allow to be covered by our insurance products, or, you know, offerings. And we've designed different plans to allow employees opportunity to select how much cost they're willing to, you know, bear. And we've incentivized them, obviously, to pick the higher cost, you know, plans where they have a high cost deductible or high deductible. So I don't think we've done anything super innovative that other people are not doing in this space.
Just a sort of last thought, I guess, on the doctors, the incentives, the salaries. Obviously, aligning incentives to work with the system and bring down costs is an ultimate goal. I think if you could flip a switch right now and put every doctor on salary, your pipeline of doctors would dry up because you haven't fixed the educational pipeline.
Not if you pay them the same amount.
Economics 101 is people respond to incentives. Doctors are incentivized to go to medical school and get specialized because there are high, well-paying, well-respected salaries.
You can pay them the same amount. You can pay them exactly what they're making now. It's the pen. It's the stupidity of all the other ordering. You can pay them exactly what they're making now. You can guarantee them exactly what they're making if they don't order stupid tests. So remember, physician payments is only 8%. It's the other junk they order.
Well, and I'll just
So
say
you can
too,
guarantee them the same salary.
from my perspective, my limited perspective, because these guys have a lot more experience in healthcare than I do. I joined Baylor only 7 years ago, so I came from other industries where I kind of came into this and went, oh my gosh, this is really screwed up, you know, oh my Lord. But so I'm sort of learning, catching up. But you know, I've spoken to physicians at Baylor, to residents at Baylor, okay, who are trying to. Most of the time, people don't understand what the cost of what they're ordering. You know, they're ordering what they think is the appropriate treatment protocol for a given condition, and they don't recognize, because that data is not available at the time that the pen is being used, or it's not really the pen anymore, it's Epic, you know, it's a keyboard. It's not like there's a menu of costs. Well, if I order this test, it's this, and if I order this drug, it's that, and so physicians don't even have that data. You know, I've talked to many that have come to my office thinking that I have that data, and I'm like, I don't have that data. I mean, I don't know what the actual cost of this therapy versus that therapy at Bentop Hospital are. I mean, but so you do see physicians asking for that information, but it's not readily available to them.
And they
Right.
ask for it a little less in McAllen than they do in the Texas Medical Center.
Yes.
And so that, you know, I do remember well waiting in a doctor's waiting room 25 years ago, and for some reason he left the door open to his office, and he was installing his own nuclear camera in his office across the street, and the salesman said, "You realize, doctor, if you don't do 8 of these a day, you're going to lose money." He said, "Oh, I can make that happen, no problem." Quote. So
Wasn't that the issue in McAllen as well? They own their own
You bet.
imaging centers,
They
and
own
they
their
were
own
overutilizing.
you bet.
I think Gawande called it a culture of money.
Yeah,
Yeah.
you bet.
But
that's
by
why
the way-
that's why your thing was so important, because they knew exactly what they were doing, and they didn't do it in Medicare.
Do you know
I mean,
do you know what Gawande is doing now?
I do.
Yeah, I thought you were going to.
He's asked me to work with him.
Oh, really? Okay. Well, he is the CEO of that. What are the 3 companies that are formed?
Amazon,
Berkshire
JP Morgan.
Hathaway.
JP Morgan.
It's Amazon, J.P. Morgan Chase,
And Berkshire.
and Berkshire.
Right. He's the CEO of that.
Yeah, they're
the
about-
healthcare.
He's got about 10 people, and I've gotten a little bit of a word that, for some dumb reason, they want me to talk to them.
Yeah.
Can I still ask something about the earlier discussion about overdiagnosis or overuse of tests?
Doesn't happen.
Yeah. We are one of the companies here at the TMC Innovation Institute in the TMC accelerators, and we're based in Oxford, focusing on risk stratification of patients suspected of having lung cancer, so that we can escalate patients to faster surgery, as well as avoiding unnecessary biopsy scans and operations on benign disease. And one question I would like to ask, I was recently at an event by the giant charity Cancer Research UK, where there was a mixture of European clinicians and American, and the European clinicians were very interested in rule-out tests, tests for ruling out disease, whereas the Americans were interested in just ruling in. And I wonder, will the value-based payments, and I understand that part of that is the fear of legal litigation, like by not doing the lung resection on somebody who doesn't have lung cancer, or the biopsy or scan on the benign patients. It's part of legal litigation as well as a commercial conflict of interest, like losing revenues out of CT scans. But the value-based, the bundled payments, they do solve the commercial misalignment, but will they solve the litigation problem that the doctors are afraid of just not ordering the extra test because of being sued?
So I'm sure everybody, I'll give you a 30-second answer, and then others, I'm sure, have plenty to say. Especially in Texas, litigation is a tiny issue. They figured out in Texas how to deal with litigation, and so it is in Texas. This is one of the best states from a litigation standpoint to be. So if somebody tells you they're doing a test because they're worried about getting sued, go look at their bank account. all right? Because in Texas especially, that's not a really good reason to do. Now, you raise a very interesting point, however, and that is similarly at Baylor, which is Joey doesn't do well by a patient. Does Joey get sued? No, Baylor gets sued. And so the question then is, well, Joey may get sued, but probably not. Baylor's going to get sued. And so the question of who gets sued and how do you protect against that is something that could take forever, that I know nothing about, that Julie probably could talk about for years. But I think your question, again, I was very surprised at how little effect bundled payments had. I was dismayed and surprised because
the right concern that I have that the bundled payments may not solve it alone, right?
nothing's going to, no, the point is bundled payments aren't going to solve payment either, at least the way they're currently done. I happen to believe that's due to a lack of systems, that the docs aren't ready and there's not enough information and all that stuff, but whatever it is, they ain't ready. There was 5% change and it had nothing to do with physician behavior. And I wish it wasn't, but it is.
Let me
Well-
address your question with a value base, and then skipping to the last question that was for today, and you're going to address that. The value-based care, somebody's got to define what quality means, what the outcomes are.
Yeah, let me go back to what Tim just said, though. I may be wrong, but I think the results you're referencing were based upon the early retrospective bundles that Medicare put out, not prospective bundles, and there's a huge difference. On the retrospective bundles, the hospitals were at risk for providers downstream they had no association with. The patient could go back 300 miles where they live after procedure, go anywhere they wanted, and the hospital was responsible for that cost. So in a retrospective bundle, there's no buy-in with the providers on the front end, no agreed upon protocols.
Article's on my desk. I'll go get it. Keep
Well,
talking.
Are you leaving?
We only
No,
have
the article's
33
on my
seconds,
desk.
33
I don't
minutes
know the
left.
answer to that, but it's sitting right here.
But on prospective bundles, you can identify who the providers are going to be. They all agree on the front end. It's a closed process. They agree upon protocols. They agree upon what they're going to be paid out of that, and they all assume risk. Another benefit of prospective bundles is the insurance payer, the patient, whomever, knows what they're paying on the front end. They know what that unit cost is going to be. The providers are assuming the risk. So you're getting closer for a patient to be able to assess value. If they can somehow learn the quality of that provider on certain procedures and the price up front, then you're talking about real consumerism where you can make a value decision on where you want to go. Right now, we don't have that. Right now, there's a lot of talk about publishing your charges. That means nothing.
Yeah. And by the way, that was one of the questions that was directed to you. Do the
Well, I mean,
charges
it's just
mean anything?
It doesn't mean anything, and you know, now this requirement for hospitals as of January to post their charge masters, no one's going to be able to decipher anything from that requirement. When you go into the hospital, you don't know what the combination of all the different things are that are going to be done to you to be able to go in and then compare, you know, hospital cost from hospital to hospital.
Not wrong.
So
Yes. you're
it's not going to be useful.
Would it solve if there, say, was a quality measure which is procedure done unnecessarily, like a biopsy or surgery done because of cancer suspicion, which is done on a patient who doesn't have lung cancer? That such a quality metrics don't exist, right? It's explicitly defined, or
Yeah, I mean, whether the quality measures exist or not, but I remember going up to the law school in Austin and saying that, and I think Tim will bear me out on this, that much of what a physician does, there's some of it is absolutely required, some of it is not required, and some of it is monetarily motivated.
Yeah,
A large chunk of it.
The problem, and we could talk about this all year, the problem is the only way to find out motivation is to ask. You cannot, I was part of a group of There was something used to be called the Office of Technology Assessment in DC, and it answered questions like this. And I was part of the group that closed it. It was the last question they asked, and that is, could you look at a chart and tell whether a doctor was practicing defensive medicine? Could you look at the chart? I.e., kid comes in with a whack on the head, and the doc in the ER gets a CT scan. Why did she order the CT scan? Money? Malpractice? Curious? Want to be sure? Right? You got to ask. And that's the problem with motivation. And unfortunately, that we're going to try and get around that in this next physician survey, to try and figure out how we can get to asking questions where we'll get the answer that they really mean. But it's tough. You can't go look at the chart. You got to ask them.
So I was going to go back to the gentleman from Finland there. So I think that, one of the problems with medicine that is, let's use the term socialized, there is a medical system in England that is a national medical system, but there's also a Harley Street. So if you have the money, you can go buy additional care. I don't know how that would work here.
That's like in Finland as well. We have both.
Oh, they have both?
Yes.
Well, that's that whole argument that's going on right now. That was my op-ed in October, where I called it the single safety net, that what we need is a single safety net like public school. And then if you want to go to private school, go to private school. Go buy insurance. The two first bills that came out, Bernie Sanders and the second one, said, no private insurance at all. Kamala Harris originally came out against private insurance, then was for private insurance, then was against private insurance, and now isn't sure. Me have not a clue how the United States of America with the insurance lobby is ever going to get rid of private insurance companies. I don't see it. So you can be as you want, but Osama, I don't think it's real complicated. I think you do exactly what you do now. You have private insurance for anybody that wants to buy it. But there's a complete floor, to me, single safety net, Medicare, Medicaid, county hospitals, the whole works, all gets thrown into one, and that's public school. And you pay taxes. You want to go to private school, if your employer wants to buy private school, your employer buys private school. Aetna still sells insurance, I think it works. I sure as hell wouldn't have the tax exclusion for that anymore. If the employer wants to buy insurance as part of something else, they don't get a tax exclusion anymore.
Okay, so let's go on to another. Oh, sorry. Did you have a question?
Yeah, I have a really basic question, and this question is about cost. How much is too much? I mean, we're talking about a law,
Good question. Yeah.
reducing the cost. I mean, we have no gauge, and you may say we've done that. We have reduced costs on this much. But really, for the ordinary people, it's still too much. So you're talking about reduction. There's no standard. And the second question I'm kind of wondering is that there gotta be somebody who can set that standard, I guess. And maybe for some country they would say, well, we have some idea. We don't want this to be over that. That's too much. But here, when we're talking about too much, we have some idea. It's too much. When I have to pay my son's surgery where he didn't have insurance, some hospital will tell me it is $40,000 for doing a bicep ruptures, to fix it. And it's like, oh, wow, who can come up with that kind of money to do that? So anyway, I'm just saying that the idea of how much is too much, that is already I don't know how
And
you
then do
can.
you really think that it costs them $40,000 to do that?
No, it doesn't, and that's the thing. And so we know this is ridiculously, and this is really so wrong. The system is so wrong, and so for me, I actually have to shop around. I gotta go ask doctors, and it wasn't not easy because it was not that easy, and it takes a lot of time to do that. So anyway, I'm just thinking, how can you even think about reduction of the cost when you don't know what is the cost?
So it's just sort of interesting. It reminds me of something I had to do for a class I took. So Taiwan pegs the amount of money that they're going to pay out of the economy of that country for healthcare. And they negotiate. They have a single payer system. They still have private insurance, but they have essentially all of the hospitals and all of the providers. If you're going to participate in this sort of government single payer system, the rates are negotiated, but the ceiling is basically pegged economically, I think, to where they want healthcare to sit in their GDP. I don't know what that answer is for America or for the United States in terms of it's too much and we can't sustain it, and we've been saying that for 20 years. I don't know where it is,
In Taiwan, they have some kind of a formula.
They do.
And I think I attended one
But
of the...
there's disadvantages to that too. So if you study that system, that healthcare delivery system, physicians are free to opt out of it, but they have to be pretty competitive. They may not have, be able to make a living. But the bigger disadvantage that I remember when I studied it is that technology, they actually pay less. They actually really probably should allocate more money to healthcare in that country, because what you see is that technology is 4 or 5 years late getting there. So, a cancer therapy that's sort of mainstream in the United States might reach Taiwan 4 or 5 years after it's mainstream here. And so I don't think there's any perfect system. There's going to be trade-offs in any healthcare delivery system that a country puts in place. You're either going to have access issues, or you're going to have technology is delayed, getting to the market because there's not enough funding there. You don't have enough physician supply. I mean, there's going to be some sort of con. There's a trade-off in any system. But that's where I felt like they were. Basically, the government was like, we don't want to be bankrupt by healthcare, and so they designed a self-contained healthcare delivery system that was pegged to what their government could afford, their economy could afford. And then they negotiated and fixed all the prices from there.
I want to go last.
No, I was going to say that same question that you raised could be asked of anything else we spend money on. How much is enough? It's not just healthcare. And most of the studies that have been done show that the more developed a country is, the more it spends per capita on healthcare. The more developed a country is, the more it spends on healthcare per capita. It's just that the U.S. is way off of that relationship line that shows that the more developed you are, the more you spend. The U.S. tends to be 30% over. So, I don't know.
So chapter 19 of the book starts out, the reason the U.S. does not have a Canadian healthcare system is we're not Canadian. And so you've got to start with who are we, right? You've got to start with the fact that we cannot tolerate not having the absolute first best hotsy-totsy, whatever, scan, drug, whatever. And the goofy thing is about half of the time the expensive drug is worse when they finally go out and look at it in phase 4 than the cheap drug. So Osama, of course, as always, is right. It's very hard anywhere. Okay, how much are we going to spend on education? I don't know. But the reason I like the Don Berwick approach is numerically, he actually calculated, he thinks, how much we waste. And it's a third, for God's sakes. Now, if we could cut healthcare costs by a third, trust me, right, we'd be back in line with what other countries spend. What's the problem? A third of the people lose their jobs. What? Yeah, so you don't just say, oh, okay, let's cut healthcare by, right? So the docs, my preaching, right? The docs go on salary. And the docs still make the same amount. Well, guess what? The echo techs don't, and the radiology techs don't, and the people that make the echo machines don't. And so all of a sudden, we're going to do something that's going to reduce the price of healthcare, but everybody downstream is going to lose. Uwe Reinhardt, to whom we dedicated the book, in 2008, when he was talking to the cardiologists, remember, 2008 was the depth of the God knows what, depression, recession, whatever. And he said, you know, there are 2 billing clerks for every physician in the United States. So there's 1.4 million billing clerks. And you probably don't need any of them. But please don't fire them right now. They need their jobs. So this is really complicated. I don't know the answer. I do think, though, you're right. But what you're calling those 2 famed words that no one has uttered yet are global budget. And you say those words in healthcare, and you'd better head for Tahiti, because somebody's going to
Or
shoot
Taiwan.
you. Yeah, right. Somebody's going to shoot you. Okay? The interesting thing about France, because I've spent a lot of time in France, they have a global budget, but they blow it every year. They don't pay any attention to it. So there are all kinds of ways of dealing. Taiwan is more disciplined. They keep to it. The French just blow right through it.
There's one equation that I think you should keep in mind, and it reflects a little bit of what Tim said. Every dollar of healthcare revenue is a dollar of healthcare cost. If you cut the costs, you have to cut the revenues. The revenues mean you're cutting out people. What are they going to do? Huh?
What is the problem with that?
Unemployment.
Well, unemployment goes up. What are you going to do about those unemployed people?
It's going to be older people and more,
Oh, the older people's okay?
more patients, right?
I don't know. All I'm saying is that just remember that one equation. Healthcare revenues equals healthcare costs. If you cut costs, you've got to cut revenues. Somebody's going to be unemployed. Who's going to take it in the ear? The doctors, the hospitals, the pharmaceutical companies? Who's going to take it? Somebody's got to make less. Who's going to make less? So, anyway, Tim, question.
Yes. Somebody here, by the way, there's a question.
There's another. Oh, you got.
I think we may have sort of dealt with it.
The access coverage
Do
issue?
you think government should play a greater role in healthcare? The VA is very well managed care, an example where government managed the healthcare system very well. I'm reading verbatim. People may or may not agree with that, but would anybody want, it's just a question from the audience, or maybe from TV.
That's not my question, but would you agree that VA is more efficiently managed than the average healthcare system?
The word efficient, my professor to my right is going to tell me you better define what you mean by efficient, right? And efficient's usually input and output and stuff like that. The VA is difficult to measure some of that. Now, it's not difficult to measure. It's difficult for me to get data on, and I've tried. So I don't know. Because, like example, a readmission to the hospital in Medicare is about $10,000 is what it costs. Or, no, sorry, it's what Medicare pays. And every time I try and look up the VA, there's one article and it says it's $2,600. I don't know what that means. I don't know what they're laying on it, what that represents. And so I think my answer is, I don't know. What you'd want to know with the VA is how much do they spend per patient and what are their outcomes? And I don't know enough about it to know. I just don't.
Let's, and I don't know the answer to that question, but look, I want to go to what's wrong with the ACA? What's wrong with the Affordable Care Act, more commonly known as Obamacare? What's wrong with it? And I think that's to you, Tim, unfortunately.
Well, I could kick it off, but I'll bet everybody in the audience and John.
Well,
and
we
Julie
have a slide. Okay. Yeah, does not lower the cost of health services, does not improve quality of care, does not increase access to care. Forget the other.
Okay, A, B, or C. There we go.
I'm killing you. Because you're always going to say other. But what's the most important weakness in the ACA?
Huh.
What does other mean?
We-
John, I'm sure did other.
We're not allowing other. But you already did it, I guess.
Yeah, I did. I put other in all of them. I mean, if you all had to design your own system, how would it differ from what we understand, those of us that have looked at it, what we understand of the ACA? What would be different?
So I'm curious, was reducing costs actually a goal of the ACA? Couldn't figure it out.
Yeah, I think it was.
Did it reduce the cost growth rate at all?
That refinement, they just said a reduction in the cost.
I think it was intended to reduce the cost to the beneficiary.
Bend the cost curve.
But actually, it just put more on them through high deductible plans, and premiums didn't go down at all.
So the total cost of care didn't go down to society.
I didn't see it.
So
You know,
you
it's an
didn't see it or it
interesting
didn't
question,
happen?
because I don't know if it was a goal. It sure as hell didn't.
Well, it was
Okay, I don't
supposed to
know
be
whether-
more
I don't-
affordable.
You know, and maybe when they were trying to sell it, they said it would.
Yeah.
But no way on God's green earth did it do anything for cost. It
Yes.
They were trying
didn't
to insure
at
more
all.
people.
You know, they talked about ACOs, but fine, they talked about them. They talked about value-based care, undefined. But the data are that cost marched right on. So
Well,
it did
but-
nothing to reduce the cost.
But there
of care.
was nothing in the past, 7 years or so where they tried to reduce cost at scale, right? They
Correct.
simply ran some experiments.
Correct.
That at small scale.
Correct. Nothing.
So they didn't really try.
Well, the
Correct.
ACA had a number of demonstration projects in it, so it seemed like they were experimenting with different ways to finance different types of procedures. Right.
John, you're frowning.
Anecdotally, with certain sectors of the market, you did see reduced premium costs. Whether it was through the free exchange, or not the free, but the exchange programs. If you looked at California and some of the other ones, they did see certain areas where the stratification was more efficient and they saw reduction in certain premiums. I don't think there was enough time to see whether there was a growth in the bend in an aggregate basis. But you did see some very interesting
I'd like to see
changes
those
in
data.
individual products.
I'd
And-
like to see those data.
Yeah.
Because I think you'd find about 96-1 against that. You might be one, or there might be, and I'd love to see how they did it.
Okay,
But the aggregate, that's the
Yeah.
problem.
The second thing that we, and I think part of it, the second thing that we saw though was, and we saw it with HCA and others, is we saw significant reductions in bad debt, which allowed the hospitals to increase their bottom line, which meant that they weren't pushing as strongly as they were in the past to increase their future rates. There's a huge, HCA, millions and millions and millions of dollars of additional revenue that they saw, and other hospitals saw the same thing. Yeah, saw bad debt reduced dramatically. And I think that was, the idea there was if they were more efficient, that you would be able to see less of a push that they would have to continue to increase their rates, which would allow the curve. And from an insurance standpoint, from employers, that was important because prior to the ACA, 1 out of every $4 of your health care coverage was to pay for bad debt.
But I
If
think,
you look at that.
but I think you would agree, and I think Jim was saying that the total healthcare expenditures continued to go up and up and up. Total.
Yeah.
The
Yeah.
real and I don't disagree. I'd love to see, because there ain't a lot of where the price went down. The real problem where they tried to stuff the genie back in the bottle and say, okay, let's just reverse all this, get rid of Obamacare and go back to 2008. One of the big problems with that is we're now that much more expensive than 2008. And so it ain't 2008. I would real quickly, what would I do? I would whack the Supreme Court over the head and I would say, how dare you make Medicaid expansion optional? I would whack them over the head and I would say that was one, they almost should have gotten rid of the whole thing. I'm glad they didn't. But the idea of making Medicaid expansion optional, I think, absolutely killed it. So I think that's the worst. The second is I listened to the secretary about 3 miles from here say, when we were doing all this stuff, we just sort of forgot about deductibles. She said it. And they did. They forgot about deductibles. Now, there were a little bit of deductible stuff that Trump has now managed to get rid of, but the real low income deductibles, there was a little bit of help for the real low income deductibles, but nothing in anybody over 200% poverty. And so and she said so. She said, damn, we really did do okay on the premiums, but you know what? We just sort of forgot about the deductibles. And duh. And so, deductibles, family deductibles now are $12,000. Great. Terrific. And so, that's in the silver plan. So I think what one would do if one were recreating it is you'd shoot the Supreme Court for doing that. You would not allow Medicaid to be optional. Better be careful what I'm saying on television. You would wish the Supreme Court had not done that. I think that was a horrible blow. And forgetting about the deductibles, thereby allowing all of these people in the middle who couldn't be covered by Medicaid in states like Texas where there's no Medicaid expansion, and there wasn't enough subsidy to pay for the people over. And then you'd say, well, what's the real problem? How much health care costs. So that if you cannot, there's just no calculus where you can achieve anywhere near coverage for everybody in the country without seriously reducing the cost of health care. Can't do it. I think the thing, and then I'm really, I've got 5 minutes, gonna really shut up. The thing that I think when people come to grips with Medicare for all, what they're gonna see is Medicare right now pays for everything. And Medicare for all, there's no way in the world Medicare can pay for everything. And so what you're gonna hear is that marvelous term called rationing. And the country's gonna go ballistic. And they're gonna say, no, thank you, I think we'll keep it the way it is now. If anybody's being honest. Because you cannot, I mean, you just can't do it. You cannot, tax your way. You've got to somehow reduce the price of Medicare, and the only way to reduce the price of Medicare is to do less.
Yeah, and one of the questions I've raised with the class at the school is how much of the increase in expenditures is due to price increases, how much is due to utilization increase? Don't know. I don't know the answer to that. But we know that expenditures on healthcare have gone up. Is it because of overtreatment, or is it because the prices are going up, and how do you separate the increase into those two components? Don't know. Questions, last comments. We have, what, 2 or 3 minutes left? Yeah,
I
Mike.
was just gonna say, if there's an organization, particularly a payer, who can implement rationing, it has to be CMS, right? So
No, because the insurance companies and the companies that they represent already do. CMS doesn't. And so there's plenty of rationing right now. There are plenty of people who cannot get drug X in Aetna that works for company X. There's plenty of rationing. Now, the place where there's no rationing is CMS. And that's where you're going to get into...
So there's no revolt, though, now. So why do you think there would be a revolt if Medicare rations?
Oh, because the only way to have Medicare for everybody is if they do ration.
Right, but if that's that safety net, it's going to be bare bones. That would be the expectation.
Will have, pick a number, 1/3 less stuff that it covers per person. Call that kidney transplants, call it heart transplants, call it cancer drugs. That's the only, you're going to have to spread that amount of money or reduce the price of healthcare, good luck, or increase taxes out the gazoo, good luck. So I think there aren't the nice thing about this is there aren't 50 levers, right? But the one that I think everybody's talking about, well, I'm not going to pay more in taxes. Okay. Well, I don't know how to cut the price of health care. Well, yeah, we do, but they don't want to do that. And so then what they're going to come smack up against is, oh, well, you mean Medicare won't cover everything it does now? And I think that's when the is going to hit the
fan.
Well, I guess the good thing about that instance is the government is the one who doesn't have to pay off their bills on time, so they can continue to be insolvent and kick the can down the road.
I think one of the things that I've always said is what % of the people are reasonably satisfied? Because in the end, it's going to come down to the votes. Right now, I think 85% of the people are reasonably satisfied. Yeah, they think it's a little too expensive healthcare, but is it really too expensive? Yeah.
Yeah, I have a sort of interesting observation that often when you talk about single payer or universal healthcare, that people give UK, England as an example, and English people, they're very satisfied about the NHS, but it's really the worst quality of healthcare of any developed European country.
Would
right?
you define that, please? Would you define that?
In terms of outcomes, yeah, looking whether in cancer, in stroke, it's much worse than whether you look at Germany, Austria, Switzerland, and in places like Germany, Austria, Switzerland, there is actually the healthcare is free at a point of delivery, but there is competition between payers and there's competition between providers, right? So I think having a kind of socialist monopoly is may not be the best way, because in England certainly it doesn't work for the patient. Yeah, everybody has access, but then everybody's getting something rather mediocre.
You may want to look at life expectancy. Those tables are in the CIA of all things. A whole lot better than the United States, the UK. It's amazing the CIA has that stuff out on public, but that's where life expectancy and infant mortality data are. I would recommend you go look at it.
And on that note, I think we have 30 seconds left. 30 30 seconds. All right, so listen, thank you all for coming here tonight. I don't know, do you all want to follow up on any of this afterwards, or? No, we're done? I think we're all done. Thank you. Thank you for coming.